It's so great to see so many very talented, very hardworking people of like mind that have this purpose, this unity of purpose of helping the wounded and injured is amazing and fulfilling to me personally, but I think very meaningful and important to our colleagues. I hope my presentation comes up. But while she's doing that, I'll also, by way of explanation, my parents were born in Ukraine. I was born in the States. I'm a retired U.S. Army trauma surgeon. My pathway to trauma and war surgery was started as a resident, where I saw the consequences of war up close as a surgeon, and that made me want to go into trauma. And unfortunately, that need, that skill set as a subspecialty was really very important when 9/11 happened, and so we took care of the U.S. casualties. And from that, I gained my experience. And I think any war surgeon, one of their desires is to make sure that those lessons that they learned, those hard-earned late nights and restless days and all that, that they don't get forgotten, that they get applied. So, is there a clicker or just?
There's not a clicker, just next.
Okay. Okay.
Yep.
It doesn't seem to advance.
Maybe just clicking on it.
Okay. We've been through that. These are the areas I'm going to cover. Okay. Compelled by this desire, I started visiting Ukraine in 2014 after the unrest and fighting that occurred in 2014. I went 3 times. But my efforts increased after in February 2022, and since I've been in Ukraine 6 times, most recently 2 months ago. And in red are the places I've been personally, and in blue are places that I've conferred with my orthopedic trauma colleagues. And certainly war is also a time when there's a great potential for innovation and advancement. And I think that it has happened historically, and what I am observing in Ukraine, they are continuing to advance and improve, and I hope that it really results in a transformation of the system, because that way all the blood, sweat, and tears that put down and the injured and the killed has some higher value. So I'm going to focus on orthopedic trauma, which is extremity injuries, and these are, as you've been all very well aware, bombs of various kinds and some high-velocity gunshot wounds, and they all result in tissue loss, and they have high level of contamination. There are immediate issues of blood loss and make sure that the life is preserved, but then there's evacuation, and then the recovery is where a lot of work occurs, but none of it can happen unless all those first steps happened. And so the challenges of the injured extremity from war is complex fractures with defects of bone, of joints, and all levels of soft tissues, and these can vary in size and complexity. And then there's infection. What is typical, the tibia is often seen as a prototypical problem area for fracture. Even in as ideal conditions as you can have during the global war on terror, the average severe open tibia needed at least 5 operations, at least took 9.5 months to heal, and a fifth of them, 20%, resulted in amputation. So that's significant. And then there's a whole algorithm you go through, temporary external fixation, debridement, cleaning it up, and then deciding how you're going to fix it or whether you're going to amputate it. And then obviously the rehab, both physical and mental, is important. I think this is an important slide for us to realize, and this makes me extremely humble if you look at the numbers. In 20 years, we had about 50,000 U.S. casualties. Any casualty is too many, but that's a lot. But if we look at the Ukrainian experience, okay, they've had 8 times the number in 1/7 the time. And if you were to correct for population compared to the U.S., that'd be 3 million casualties for the U.S. That's unfathomable. And what they've been able to do with this is simply amazing. So the burden of disease from wartime trauma is the extremity. It's the most common. It requires the most resources, and it has the highest disability costs. And despite all of that investment, there is still imperfect results. Those patients that have severe injuries to the extremities can be considered, compared to population norms, disabled. They do incredible things, but they still have significant defects, and their bone may be healed, their muscles may be working, but they still have significant deficits, and they never really return to normal. So the common practices in Ukraine, particularly before 2022, was fairly limited debridement. They either were ex-fixed or casted and with some wound care, and then if they healed, then you dealt with whatever result you had with whatever means you had. And this is a result of their system. Okay, it's a legacy, and I don't mean to be critical, because for sure the U.S. system has a lot of things that we can criticize ourselves about, but siloed care, it tends to be bureaucratic. There's not really a culture of quality improvement, data collection, outcomes assessment, and they have very limited resources. I can call my OR and I can have any tray I need, well, almost, and do what I need to do. There, it's a different system, we'll see. And then this is also based on the fact that for the orthopedic trauma surgeon in Ukraine, their typical training is 2 years of residency. For us, it takes at least 5 years, plus if you do a fellowship, that's an additional year. They do have some fellowship kind of equivalents, but to understand the vast amount of knowledge, both anatomy and principles of care, within 2 years, you may be a genius, it's still impossible. And yet we're asking them to be able to perform at this high level. Fortunately, they have a very motivated and young staff. They never fail to impress me when I'm there. Last February, we had one nurse that was running 3 ORs by herself. That would never happen in the United States. Their unions would go bananas. Another point of context, okay? All these patients, in the U.S. ward, they all went to military hospitals. There's too many. They go to civilian hospitals and the military hospitals. If you look at this graphic, you can see in the green is the civilian population of that hospital census. That still stays there. It doesn't go away. And then they have all their military patients. These are the types of cases they do. Significant number of increase in all types of trauma care. And the resources haven't really changed. If you look at their average monthly census, it's 6 times greater with no increase in staffing. A challenge to anybody. So, as an orthopedic trauma surgeon, we're very dependent on implants. We need tools to fix bones, to get them and restore function. And they generally fall into 3 different categories: internal fixation rods or plates, and external fixation of various kinds. I'm not going to go into the details, but we have a huge array of these tools to be able to address specific problems in specific anatomic areas. In Ukraine, that is very limited, okay? A lot of it is dependent on donations. If it is, then you have all the odd sizes because they're not using them anymore, they're out of date, or they're incomplete, or a combination of thereof. You have knockoff products which are of inferior manufacturing quality and manufacture. And so it doesn't quite perform under the conditions that you're asking this injured soldier to recover from. These are very common pictures, and every hospital I've been in, it's something like this. That is your tray of nails. Your plate's too long? Well, you cut it. That's a sterile, industrial size bolt cutter, okay? And then the resident has to rummage through stuff to find whatever implant they need, okay? Imagine how much time and effort a surgeon has to do in order to do this. That could be better used otherwise. And yet, okay, their care has evolved tremendously. What I've seen in the last 3 years, they're much more adept at and not afraid to do an extensive debridement. That's the key first step, okay? Use of antibiotic spacers. Converting to internal fixation of various kinds. There are limitations, and I'm not going to go into the seminar on that, of external fixation. If you can internally fix, then that limb can move, and that person can get out of bed and work on their mental and physical recovery. Okay, when I proposed some of that before 2022, they looked at me like I was some crazy dude. So they're starting to implement these means. Local rotation flaps, extremely rare prior to 2022, and since that time, more and more, but there's still plenty more to do. Free flaps, transfusion of whole blood. Lida has worked very hard on making sure that they have blood transfusion at the front line, but it's still a difficult process because of the way their system is set up in order to have that readily available where you need it. Vascular reconstruction, you never saw a limb that had a vascular reconstruction that you then had to reconstruct the fracture because they didn't do it. Now they do happen. They're still challenging, but that is an example of the evolution of their care. And then life support. There are some instances, and I don't know how close to the need they have, but they can use dialysis close to the front line and extracorporeal oxygenation. They can use this, and how much do they use and how much do they need, I don't know, but those are clearly evolutions of care. In general, these kind of severe traumas require a traumaplastic approach. When they didn't have those skills, they couldn't apply it. But if you have a big open wound, you have to be able to clean the wound. That'll leave a defect of soft tissues. And if you can't cover it, you can't fix it. So now, if you combine those skills of cleaning, covering, and fixing, that's the traumaplastic approach. And the skill level has vastly increased because there is a need. And there are willing and talented surgeons that have learned how to do this. In microsurgery, you saw the oral maxillofacial presentation. The same applies to the extremities. So these are just some quick examples of various types of local rotation flaps which allow for fixation of fractures underneath them. Okay. The conversion to internal fixation has allowed a rapid recovery of these severe injuries. And you can see the numbers. This is one hospital, the Border Guards Hospital, where they're using fairly advanced techniques to deal with very, very difficult problems because you can cover it and you can fix it, but you need skills on how to apply this. It's unforgiving if you don't practice it. Okay. Here's another periarticular reconstruction, a very complex injury involving the elbow and the forearm. This was a stage kind of procedure. You can see that they went through the steps, and look at that result. That is very impressive for something that you never saw 5 years ago. okay? And they've also been able to innovate in various ways. Here's some examples of 3D printing to create custom implants. And again, you can use this for specific instances and specific problems, but the need is very large, and we have to critically assess their outcomes. Yep. Here's an example of an extreme shortening. You know, usually it's considered that in the leg you can shorten it about 3 or 4 centimeters. Beyond that is very risky. Well, you have this big defect of not only bone but all the soft tissues. So what they've done, and they used a little bit of the Israeli experience, they've acutely shortened it. With that, they can close that wound, and then over time you stretch the bone and you get a fairly impressive result. You can imagine, though, this takes a lot of time and a lot of effort. Here's another fairly unique example of some of the innovations. Landmine injuries are considered a indication for amputation. But you know, they have the numbers and they're developing the experience to figure out which ones certainly need amputation, because certain ones still do, but maybe there's some that you can salvage. And this is an example of where they were able to do that. They did it in stepwise fashion. They cleaned it out, covered it, stabilized it, created a custom implant, and he's able to walk. Now, I don't know how this is going to look in 5 years. A flap that goes and replaces some of that very thick skin on the bottom of your foot, it's very hard to make durable. And there's a distinct possibility that this will open back up, get infected, and then the result will be an amputation. But there's still some that, you know, you're right on the edge of that, and maybe it'll work. So there are continuing challenges, infection, non-union, just poor function. You know, the limb is contracted. That muscle has been traumatized. They've been immobilized. The tissues scar down. They can't move the limb. And so you've done, the bone's healed, there's no infection, but they can't use it. Nerve injury and muscle loss are real problems. And then some have used arthroplasty to replace damaged joints. So these problems will continue over time. This is an example of a non-union that required revision surgery. I think a problem, not just now, but for the future, is going to be in osteomyelitis and deep infection. These are commonly, I know you have a session on infection, but I'll touch base from the orthopedic standpoint. These are polymicrobial and polyresistant. It's related to, but not exclusive of, limited initial debridement, poor antibiotic stewardship, poor isolation and hygiene practices, and the multiple stages and movement of patients. Those are all things that can increase the probability of having these difficult infections. Once you get a deep-seated infection, it becomes very hard to eradicate it. It requires multiple operations. This is an example from a few months ago that I encountered in one of the hospitals I worked in. Yes, it has evolved over time. They're better at this than they were 3 years ago, but there's still continuing problems with infection. And infection, even in the best of circumstances, given the type of war injury, is going to loom large. So this is an example of the sheriff. He's been in the hospital in Ternopil for quite some time. Very nice man, but he has this very big problem. He's had that draining sinus despite over 30 operations. He doesn't want to have an amputation, but he can't get up and walk. But, you know, how much of this bone do you take away? What do you do with it? Those are real questions and real issues, because once osteomyelitis gets into bone, it can be very difficult to take care of. You put in a metal implant, and then that infection comes back out. So what are the things that have really helped them achieve some of these successes? Well, there are some that have realized that education is really important. They started off in 2022 with a lot of online lectures, very vigorous participation. You can do quite a bit with lectures, but not everything. That has evolved into seminars and conferences in Ukraine, as you can see some examples here, okay? But I think also there's been a number of partners, like many in this group, that contribute to their educational efforts. And just by way of example, and there's probably other professional societies that assist our Ukrainian colleagues, but I can mention this because this is what I know, and that's the OTA. They have made all of their educational resources available to Ukrainian surgeons, and it's quite a bit. And they have used it extensively. The number of hits is in the thousands per month. And this is a fracture book, a comprehensive fracture book that came out in September. And right now, Ukraine is the #2 user after US. And if corrected for population, they're the #1 user. So the take home there is a real desire to learn. And if we can support them in that, it'll be very valuable. And when their delegation came to Montreal last year, it was an incredible two-way exchange of information. And those kind of efforts really, I think, are valuable both to those Ukrainian surgeons, but to us out here in the peaceful West. In-country courses, I'll mention that in a second, but clinical rotations are useful surgeons going to Ukraine and having them come to North America and Europe. Some of this has culminated, interesting, I just heard, the Ukrainian delegation was asked to go to Lithuania to present their experience in war trauma surgery. So given the volume, given the numbers, yeah, they're becoming recognized as currently the most knowledgeable about this, and that as properly as should be, and if we can support that, they'll be extremely valuable. And I think the other thing that I may be out of my lane when I mention this, but residency training reform, I think, will be extremely valuable. If we look at it critically, 2 years is not enough in orthopedics. The other setup they have certainly leads to deficiencies, and if you're asking these surgeons to do incredible things, we need to give them the tools to do that. This is just an example. This is we've done 2 courses now with the support of Razum, deformity course. Incredible response. You put out the flyer. Within 3 days, for 30 spots, you have 150 applicants. You can't take them all parts of Ukraine. And when you're there, you can see how eager they are to learn and how skillful they are. Another thing I think will be extremely valuable going forward, they are implementing things in the numbers that are not accustomed to from other conflicts because they just don't have the numbers. But we don't know how well they will work. And so registries are becoming recognized across the world as an important tool to track and understand what are the results of our efforts. And there's 3 different areas I think that would be valuable. You may have heard of osseointegration. That's where they have like a tooth implant, but for your limb, so that the stem sticks out of the skin, subject to infection, but they've worked on that, and they're pretty good right now. Very popular. It's very interesting to use, and patients do love them. The thing is, and I spoke with Dr. Majerus, who is a worldwide leader in this area. He's been to Kyiv and Lviv to help them do these things. But his concerns remain that This is a technologically complex area, subject to issues, and they need to be tracked, and he's concerned that they don't necessarily have the tracking mechanism to know what's going to happen with these a year out, 5 years out, 10 years out, to really know the outcomes. And it would also be a huge benefit to the worldwide audience. The same goes true with joint replacements. These joints are devastated. We want to give them function. Replacement is useful. And then you have the tumor prosthesis HUD. Okay, so these are also very valuable, but this is a difficult environment given the complexity of the injury and the propensity for infection. We don't know how they're going to function long term. So some of my concluding thoughts: there's tremendous talent, as you can see. Raising the floor would be extremely valuable for all Ukrainian surgeons. There will be continuing needs after the war ends for these extremities. There'll be non-unions, there'll be malunions, there'll be infections. Those infections can ultimately also result in cancer. And unfortunately, we all pray that the war will end soon. There'll still be unexploded ordnance. So somebody will go in the woods and a bomb will blow up. And so they'll have these injuries going forward. We need to remember that. Educational support will be extremely useful. I think engagement of your professional societies can be extremely valuable. And then support the evolution of the Ukrainian medical system. Slava Ukraini!